So I would like to, again, thank you, Mr. Dewberry, very much. But we want to introduce Dr. Ondersma, who is a professor in the Department of Obstetrics and Gynecology and the Division of Public Health at Michigan State University. His primary interest is in population-level interventions promoting maternal and child health in underserved communities, particularly via technology-based brief interventions for substance use in the perinatal periods. Doctor is involved, studies technology as a way to identify and address non-treatment seeking persons with unhealthy substance use, particularly pregnant and postpartum women. His current work includes, one, a significant focus on community-engaged research to promote health equity, particularly technology-driven prevention of preterm births, and two, the development of a crowdsourced trial network using multiple arms, common measures, and a competition model in the pursuit of cumulative increases in intervention efficacy. And I'm sure he will explain all of that. So welcome. Where'd you go? There you are. You got to explain all of that.
I'll do my best. Thank you. Thank you very much for that introduction. And I want to thank Mr. Dewberry for a fantastic and inspiring talk. I'm a big supporter of harm reduction methods. And I hope to talk a little bit about the way that I think technology can contribute to that kind of work. But he's a hard act to follow, but I'll do my best here. I'm going to talk generally about trying to think differently about substance use during pregnancy. I'm going to raise some questions about the way it's normally thought of, because I have some concerns about that. I'm secondly going to talk about what I think is the value of a public health driven approach, partly because I think it's going to solve the sorts of challenges that we need to address better and faster. And partly, I think it's more consistent with justice and fairness that's so important in this area. And then finally, I'm going to talk a bit about technology, which is my real passion. Technology is absolutely not the only way to address the many important challenges that we face and in trying to help people who are dealing with substance use disorders. But I think it has a very important role to play. And I'll share a little bit of that enthusiasm and hopefully give you a sense of what it looks like. Okay, and I'm certainly going to leave time for questions at the end, and I look forward to hearing your thoughts. So first, I'd like to talk a little bit about prenatal substance exposure generally. And in the process, I'll be sharing some of my questions about the way we think about it. But first, I'd like to just start with this. Let's think hypothetically for just a moment. Pretend that there's a new substance out there that's being used by people, including pregnant women. And I'm going to give you some facts that we know about it. And this is just hypothetical. Let's say that we know it's associated with increases in low birth weight, miscarriage, preterm birth, sudden infant death syndrome, and altered neurobehavior. It's associated with behavioral and emotional difficulties later in life. And we even see differences in children's brains when we look at them using MRI scans. Okay, that's what we know about it right now. I'd like you to think a little bit about how we should respond with these facts. This is all we know. What should we be doing about it, and how should we be responding? I'll ask you to think just a little bit about that while I go on, and I'll return to this. So in general, and this part isn't hypothetical at all, we know that exposure to substances prenatally is associated with a number of effects that aren't good. It varies by substance. There's a lot of different research suggesting different sorts of effects for each substances. There is a difference between effects that we might see at birth, those that we might see in early childhood, and even suggestions of effects long-term, well into adolescence and adulthood. I won't go into this in great detail because I think you get the gist from just this slide. And then, of course, there are opioids. In my relatively short career, I started in this work basically in 1995. I've seen three waves in which there's been a great deal of concern focused on substance use during pregnancy. The first was cocaine, the second was methamphetamines, and now it's been opioids. And these have each been attention-grabbing, headline-grabbing social phenomena. Okay. Opioids are obviously the current concern with increases that you see here, both in terms of the extent to which infants are being exposed to opioids during pregnancy, and also increases in neonatal abstinence syndrome. As you can see here, these things are not rare. So illicit drug exposure in terms of any drug, about 5.4% of all pregnancies. Okay, 4.7% of that is marijuana. 1.3% are all illicit drugs other than marijuana, and 0.9% is opioids. Okay, keep in mind that that's going to look small, and it is relatively. Opioids are not nearly as common as many other substances, but they are disproportionately risky and damaging, and particularly associated with mortality, far more so at a far higher rate than other substances. So when we look at just this, think about that hypothetical scenario that I raised. If we look at just these facts and make some conclusions, here's some that we might draw. We might say that illicit drug use is prevalent and it's strongly associated with significant negative consequences. And by the way, I'm not endorsing these right now. I'm just saying these are things that you might draw from these facts, right? We might say that illicit drug use during pregnancy is a unique threat to short-term and long-term child outcomes. And we might say that obviously the thing we have to do over and above everything, really the only thing we can do, is promote treatment engagement, whether that's medication-assisted treatment, whether it's other forms of treatment. We've got to just promote that treatment. But what happens when we zoom out a bit? That's looking really closely under a microscope at that particular issue. What happens when we zoom out a bit? Well, I'll suggest some questions that we maybe should be asking before we decide how to respond. Do you remember that hypothetical scenario? And I asked you to think about how we might respond to that new substance that's out there. Hopefully, some of you said, I don't know yet because I have questions. Here's some questions we need to ask. How big is the sample size of the studies that show these negative effects? Is it a tiny little handful? Is it 5, 10, 50? Or are these great big representative samples? What other factors were controlled for? So for example, if we look just at moms who have used that substance and compare them just to moms who have not used that substance, they might also have other differences. They differ in whether or not they used that particular drug, but maybe they also differ in whether they smoke or drink alcohol or have experienced trauma or were able to access high-quality prenatal care. Those things can also result in differences. How large are the effects? So people like me, scientists like me who do this kind of work, can sometimes be a little bit, maybe unintentionally misleading. I'll be generous. We can make a big deal out of effects that are actually very, very small. So we need to know how big these effects are. Is it a tiny little difference or is it a great big difference? We need to know how many outcomes were considered. So another way that scientists can kind of cheat a little bit is they can look at 100 different outcomes. Just by chance, some of those things are going to look different for moms who have used a substance versus those who haven't. Doesn't mean it's a real difference. How does it compare to other risks? So is the risk of this new substance greater than the risk of not getting high quality prenatal care? Is it greater than the risk of using tobacco? These are really important considerations in how we think about this. How are we responding to similar risks? So if we decide to respond really strongly and get the courts involved because this new substance is hurting babies, is that consistent with how we respond to other risks that are just as big or maybe even bigger? How prevalent is it? Is this something that's being used by hundreds of thousands of pregnant moms? Or is it a tiny little thing that's being used by only a fraction of them? And then finally, if we focus on this, are we really targeting a particular group? Is there a particular demographic that tends to use this substance? And if we decide to really focus hard on this particular substance, are we intentionally or otherwise choosing to disproportionately and in a biased way focus on one particular subgroup? These are incredibly important questions that we have to think about before we start to decide how we're going to respond. So in the past, these questions were not asked. I can't emphasize that enough. So during the initial wave of this, when it was cocaine and really crack cocaine that everybody was talking about, nobody asked how big the sample sizes were. Nobody asked whether it was a particular group that was being targeted here. Nobody asked whether they were controlling for use of other substances like cigarettes and alcohol that might have been actually driving the effects that we saw in the early research. Okay. It was a great big deal. Women were put in jail. Women had their babies taken away from them based on a lot of assumptions, based on a very tiny little bit of research that in fact turned out, well, let's talk about that in a second. So one good thing happened after all of that. Somebody decided that we needed to do a really good large study to really know what the effects of cocaine were on long-term child development. We needed to do a really good study with big samples, long follow-up, making sure that other substances weren't actually resulting in those negative effects. All kinds of things needed to be looked at very, very carefully. And that was called the Maternal Lifestyle Study. It was led by my colleague, Barry Lester. Very first paper that came out, well over 1,000 infants, 658 who'd been exposed, and 730 who had not been exposed, were evaluated for outcomes at 1 month of age. Looking at 26 different possible outcomes, cocaine-exposed infants looked a little worse on 2 of them. For opioids, exposed infants looked a little worse in 1 of them. That was all they found. Let's keep going. What about when they're 3 years old? Same babies, same really strong research design. No differences on any of the outcomes that were looked at, even when they looked at the highest exposed versus non-exposed. So what did matter? What really predicted how well these babies were doing? Mostly poverty, maternal care, and whether or not they were low birth weight from the start, which is a really important factor. And later on, at 7, we do see some differences here. Cocaine scores on a particular child behavior measure were better if they hadn't been exposed to high levels of cocaine. But those factors were just as well explained by tobacco and alcohol. In other words, tobacco and alcohol were at least as important in child outcomes as the cocaine use. Here's one conclusion, and I think this is really important, that came out of this research, and this is from NIH, from a neonatal research network. It's now well documented that scientific reports in the 1980s were exaggerated and incorrect in their portrayal of children exposed to cocaine in utero as irreparably damaged. Current research does, however, suggest that the effects of cocaine are inconsistent, subtle, and need to be understood in the context of other substances in the caregiving environment. In other words, cocaine is a factor, but it's absolutely not the only factor. And in terms of that, this is the same slide that I showed you earlier. Remember that 5.4 and that 0.9 for opioid use? But I'm including all of the other substances that pregnant women sometimes use. And you'll see that alcohol and tobacco are far and away the most commonly used. And I can tell you very clearly right now, and this is extremely important, tobacco use is no more or less harmful than other substances in terms of long-term outcomes. And alcohol is worse. So when we think about the right way to respond, and when we think about whether certain groups are being targeted, we need to think about how we're responding to alcohol and tobacco use in pregnancy. Just in terms of relative effects, this is one study by some folks at Wayne State in 2014 showing that tobacco was more strongly associated with reductions in birth weight than alcohol or cocaine or marijuana. And then, of course, when we treat one drug as really, really critical, as worse than the others, as associated with terrible outcomes, then we start screening for it. And what we know now is that that screening process is irreparably biased. In one of the early studies, African-American and low-income women were 10 times more likely to be tested and thus to face a lot of possible negative consequences as white women. In a more recent study using what they hoped would be a much better, fairer, kind of objective screening protocol for who gets tested, found that that bias still remained. The other thing we know is that when that is there, when there's sort of a punishment-based or high risk of sharing, women don't share. They choose not to disclose substance use to their doctors and other care providers, which is the opposite of what we want. We need them to be able to share so that we can help them. So here's kind of the bottom line question that I would ask. Substance use in pregnancy, is it a crime? Like assault and battery and theft and assault and murder, and should the courts be involved? Is it child maltreatment, like physical abuse and sexual abuse, and so it's a child protection matter? Or is it more best thought of as a public health issue, like mental health, like smoking, like promoting positive parenting? I'm certainly in favor of the latter, and I think that there are some things that we can do using that perspective, including using technology. So if we approach it from that perspective, the first problem we have, and this is another really important thing that you may not have heard before, that only about only about 2% of folks in any given 12-month period who met criteria for a substance use disorder felt they needed treatment and made an effort to get that treatment. Another 3% felt they needed treatment but didn't make an effort, and the other 95% didn't feel they needed treatment. So it's absolutely critical that treatment be high quality and available, but it's also critical that we go out and find folks. Don't just wait, but go out and find them in proactive ways, exactly like we heard just a little bit earlier. One way to do that I've been very interested in is using something called SBI, Screening and Brief Intervention. You might have also heard it referred to as Screening, Brief Intervention, and Referral to Treatment. So SBIRT in that version. It works like this. In a healthcare setting, universally screening everybody for a given risk like alcohol use or tobacco use. And those who screen positive get a brief motivational session. And these motivational interventions are really important because they don't presume that somebody is ready to start changing. They help them get ready to start making changes. It's been the subject of many randomized clinical trials, a lot of high quality evidence suggesting that it can work, but it's hard to do. It's hard to get out there into healthcare settings. I think technology has some real advantages here. So technology can be much easier to do than trying to train clinical staff and somehow have them find the time, which they really don't have. These are very hardworking, very kind of overextended people, and they don't have a lot of time to do a lot of additional things during a normal healthcare encounter. It can be engaging and personalized in any language. It can facilitate disclosure. We know that people are often more likely to disclose stigmatized things like substance use when they're working with technology as opposed to talking to a healthcare provider. It's consistent with social distancing during a pandemic. So we can actually start thinking about electronic screening and brief intervention in healthcare settings. And it can work like this. So it's certainly not extended treatment, and it's certainly not a replacement for that. Remember, we're talking about people who aren't actively seeking treatment. We're going out to find them. So they're not offering us a whole lot of time. They're not signing up yet for multiple sessions of real intensive treatment. But maybe they're saying they're willing to talk to us a little bit. They're willing to use our application. So we can have an initial contact with them during a healthcare encounter. And then we can follow up with text messages that keep promoting treatment, that keep letting them know what's available to them and encouraging them to click to get contacted with somebody. We can keep sending them content through their phone's patient portal if they happen to have one. And then we can keep doing this over and over again each time we see them in a healthcare setting. So in a 9-month pregnancy, one way this might work, if we think about number of drinking days per week, that when we contact them initially and we realize she's using alcohol during pregnancy, let's provide a brief intervention. And then we can contact her again and again during prenatal care while also sending tailored text messages that are designed just for her throughout that pregnancy, in an effort to keep nudging those behaviors down and keep reminding her and giving her options, including treatment if she's willing. So my usual day job is doing randomized trials where some women get this brief intervention and some women don't, and we follow up to see if we're making a difference. In a number of studies, we've shown that we're about doubling abstinence when we do this. We're getting some exciting results from this. And in one particular study, when I talked down here about person versus machine, we randomly assigned women to get a person-delivered brief intervention, so from a doctor or a social worker or a nurse, or the software, or a control condition. What we found was that the software worked at least as well as the person-delivered brief intervention, but it was much more cost-effective. So that's the basic idea, and I'll summarize quickly. I'm concerned about kind of courts being the primary driver of how we respond to substance use during pregnancy. I think public health approaches have a great deal to offer. I'm also troubled by the fact that while as hard as it is to find enough services for women who are ready to seek treatment, we're also missing the many, many women who aren't feeling quite ready to seek treatment, and we need to reach out to them. And I've done some work showing that, believe it or not, technology might be able to help be part of the overall picture in terms of promoting changes and helping people get connected with care. So the next step then is kind of what happens in the real world, right? The work I've done up until this point really is focused a lot on very scientific rigor and having research assistants do most of the work. But can we get it out there, and can we make it work the way that we would hope to when there aren't research assistants around? That's what this part of the work is about. We're doing that in 2 places right now. One is called the High Touch, High Tech Project. It's been focused on rural prenatal care clinics throughout Michigan. We screen for and address all forms of substance use, including trauma and depression and anxiety. And it's been designed to use this electronic screening and brief intervention approach that I've been talking about in combination with access to a therapist through telehealth. So we're trying to make it so easy that women could simply click a button while they're working with our app and then get connected to a counselor through telehealth. The other project we're doing at Henry Ford, that's led by my colleague Amy Laree from Henry Ford Health System, and it's focused on alcohol use among women. Talk mostly about the HT2 project, the project that's being done at clinics throughout the more rural areas of Michigan. Has a lot of partners. The funders, I'm very grateful to all the funders, especially the Michigan Health Endowment Fund, also the Michigan Department of Health and Human Services and Munson Healthcare. My primary partner in this is Maria Music from the University of Michigan. A number of other folks have been important contributors to this. It works like this. So when a woman comes in for her first new OB appointment, that means that's her first pregnancy appointment, the receptionist hands her an iPad and a pair of disposable earbuds that she gets to keep so that she can use the software privately while she's sitting in the waiting area. The software reads everything aloud. There's a little character who you'll meet in a second who points to things, talks about things, summarizes everything, reads questions out loud, etc. So it's really kind of user-friendly and easy to use. The patient uses the iPad then to complete the screening and brief intervention. Some of that information, some of her answers get sent to her doctor automatically, and she knows this. Some of the other information is actually kept confidential unless she decides it's okay to share with her doctor. We thought that that was a good way to try to get the best of both worlds. We want that healthcare team to get as much information as they can get, but at the same time, if a particular woman is concerned enough about her safety that she's not ready to share with her healthcare team, we still want her to be able to benefit from the information that the software can provide. So we make it up to her. So far, interestingly enough, 95% of women have chosen to share all of the information with their healthcare team, which we're very happy about. So after the woman finishes using this iPad while she's waiting to be seen, a report gets sent to the clinic staff. So they have a nice summary of all the information that the woman has chosen to disclose, letting them know where she's at and where they might focus their attention. So this really helps elevate the major risks to the attention of those nurses and doctors and that whole healthcare team. We also can send text message alerts. So if the doctor wants, for example, one doctor we work closely with wants an immediate text message. Anytime anybody reports heroin use, she wants to know right away so that she can get involved because that's her particular expertise. So we're able to do that for her. This is some of what it looks like. So this is Petey. He's the little character who flies around and smiles and does different animations and talks out loud for the woman. This is him introducing what we call the mom's health checkup. This is how he might ask a question, and she just has to tap on an answer to provide her answer. She can use a slider like this to indicate kind of levels of agreement or with a certain question. And by the way, you notice this question about how ready she feels to be pregnant. We have a number of other questions also embedded in here to try to make sure that it's not an overly negative process. We ask about sleep, we ask about nutrition, we ask about all kinds of things so that the experience isn't just one of, you know, is this happening? Is this happening? Is this bad thing happening? We want it to feel like a positive overall health checkup. So then when she's all done, she can get feedback. And this is Petey here kind of pretending to read off her answers, and he can summarize everything she said in a very natural way and check with her to see if that's accurate and if she agrees. Based on her answers, he also can show her a video. So these are Dr. Jones and Dr. Hansen, and we have multiple versions of this video. So everybody doesn't get the same one, depending on the substances she endorsed, the risks she endorsed, the concerns, the hopes, age even. We can provide a video that's tailored to that particular woman in the hopes that it will feel relevant and useful to her. In terms of then trying to promote all her options for treatment seeking, we list those out. Petey will talk about each of these in turn, and then we let her simply pick if she's willing to do one of these things. Then we're able to take and say, okay, and put that in the report so that the healthcare team knows right away that she's willing to get help in one of these areas. This is another way we're able to do that. She can check the very specific things she wants to do. We're also developing the ability for women to sign up right away for example, early home visitation, so that she can answer all the questions that she needs to, and that information goes to the home visitation program so that she can actually be signed up right here without having to take any other additional steps. And we're excited about that and hoping that's really going to promote that really important resource for women who need that help. In terms of results so far, we've screened well over 2,000 women now using this particular program. We're seeing at some clinics rates of iPad use in the low 90% range. That means of the new pregnant women who come into that clinic, the vast majority of them are working with the technology. And that's really important to us, because if we can get that 10-minute window of women working with the technology before they're seen, we can keep trying to make what we do better and better. We can try to find better ways to help her feel safe in disclosing the things that she might need help with. We can try to find better ways of encouraging connection with home visiting and talking to her treatment team and getting care from local agencies. Whatever we can do, we can use that window to keep trying to make it better. So we're really excited about that. Very few women say that they'd rather not use the technology. They of course have that right. It's not a requirement at all. Some Amish women, for example, in the rural areas of Michigan will choose not to work with the technology, and that's perfectly fine, but those rates are pretty low. At the clinics where we're doing this right now, we're seeing about half of women screen positive for one or more risks. So this is smoking or alcohol or depression, et cetera. And those are the most common. The tobacco, marijuana, and depression are the ones that we see most of. Although we certainly do, of course, get some reports of opioid use that we identify through this process. And then between half and 2/3 get that brief intervention. Note that it's optional also. They don't have to hear the feedback. They're asked if they want to hear it. Most of them choose to do so. And we're getting satisfaction ratings of about 4.4 on a 1 to 5 scale. It's really important to us that this overall process be one where they feel that it's easy to use, that it's respectful, that they liked it, and that they would do it again. And we keep getting more and more feedback that's mostly positive, but we also find places where we can improve, and we're continually trying to do that. There's some challenges as well. So when I first got into this work, I thought, wow, if we could make technology that actually worked, how great would that be? Because it would be so much easier to implement. And to get out there and find all these women who aren't seeking treatment right now, but might benefit from services. And I still believe it's true that technology has advantages in terms of getting implemented out there in the real world. But there are challenges as well. Each new clinic and each new health system has its own process for approval. And it's very natural, of course, that they can't just welcome all kinds of different technology into their system. They have to make sure that it's safe, that their patients are protected, that information is protected. Clinics have been almost universally really enthusiastic about welcoming this technology in and making use of it, but they're just very, very busy. They have a lot going on, and I'm not the only one knocking at their door with what I think is a neat idea. There are lots of other people too, and they only have so much time and so much bandwidth. So when we need to have meetings, when we need their input, they want to participate, but they also have a lot of other things going on. The thing that's interesting is that I went into this thinking the brief intervention, I can use that to help them be ready to make changes and help them to be more likely to take advantage of any available treatment services that are out there. And the clinics are all about that, but they're really about the information. They like getting that report. They like knowing where things are at. They're healthcare providers. They're good at tests and seeing the results, and they like to have those data. We've had challenges on the telehealth side too, not just with the technology. It's a whole new level of kind of approvals, et cetera, when you try to bring in a telehealth provider from another system. There are lots of limits about, ability to bill, which we haven't needed to do because these are grant funded. But at the same time, to make it sustainable, it would need to be something that they could bill Medicaid for. And sites are often concerned about their staff being replaced by what we do. We really see what we do as a replacement for kind of that big vacuum that not much usually happens with women who aren't seeking treatment. It's just so hard to identify and motivate them. But that's certainly an issue that we have to keep our eye on and think about a lot. So those are my thoughts on this, and I'm really interested in your thoughts. I think that prenatal exposure to substances is absolutely a risk, and it's real, but illicit drugs are not worse than legal substances. And they also don't differ from things like prenatal care and nutrition in terms of how powerful they are. So I think we need to keep all of those things in mind and respond in a way that is supportive and safe. I think that public health approach has a great deal to offer. And I think that technology might be one good way that we could enact that public health approach that's safe and that helps women to make changes and to access services that are available to them. So I really appreciate your listening to me and your attention, and I'd be delighted to take any questions at all. Thank you.
Thank you very much, and thank you for explaining all of that. And I'm excited. Data certainly is something that drives many of us in this area, and new technology as well. One question came in. It says, does the SBI integrate with the electronic health records platforms?
Oh, that's a wonderful question. The answer is yes, absolutely, but it's hard. Right now, electronic health record data don't talk to each other really well, and they don't talk to other apps really well. So we've done it at Henry Ford. They are currently talking to each other, but honestly, it took a lot of money and a lot of time. One of the things that we're working very hard on right now is making this technology consistent with what's called FHIR. It's FHIR, Fast Healthcare Interoperability Resources. Which is a new language that's going to make it easier for healthcare records to talk to each other and to talk to other technology. We're taking that step on our end such that when new electronic health record providers also move towards that same language, which they are fairly quickly, once that's done, it greatly facilitates it. It makes it much easier for them to talk to. So absolutely, it's possible. It's not super easy, but it's going to get easier. So currently, what we do, honestly, is we send the reports to the healthcare team as an encrypted email. So it's perfectly safe to send that way. They get the report, they print it out, and then they have access to it. So we're able to get them the information right away, but it's not a perfect solution, and we're working hard to get to that real electronic record interoperability.
All right, we're looking at technology as a way of improving healthcare, is essentially what some of the things that you're saying. We also know that the SBIRT is screening, brief intervention, and referral to treatment. So is there a referral process? And one of the hesitancies that many doctors have shared was, if I diagnose this as a real problem, how do I get access to help? And if our system is not robust enough to provide the types of help that is needed, why then do I need to make this diagnosis and take the risk that there's no help there? So how are you going to integrate the ones that need referral to treatment?
Yeah, that's a great question and a very, very important issue, especially in the work that we're doing in rural areas of Michigan. Some of them have a surprising number of resources. It's really impressive what people have been able to put together, and others have almost nothing, as hard as they've tried. So it is very difficult. We're doing a number of things to try to address that. It's simply a problem. I mean, I'll say that and I don't have a fix for it, but here are the things that we're trying to do. One, that telehealth piece that we're trying to integrate, we're hoping can be a really important resource in areas where there's nothing else available. If women can simply click a button while they're using our app that says, yeah, I would like to talk to somebody, and they can do so right away through that iPad or through their own device or through that same device, coming back to the clinic at another time, that would be a huge benefit. And we're trying hard to find ways to make it easier to make that available. And I'll give you just a bit about one option. Most of you are probably familiar with tobacco cessation quit lines. If you're not, it's a free service. Anybody, absolutely anybody, can call 1-800-QUIT-NOW right now and can get connected with a coach with expertise in helping people quit smoking. And they'll get that live coaching over the phone. It's that easy. No muss, no fuss. That's it. I would love to get our telehealth piece to the point that it's that easy to also connect with somebody to help with a range of other needs, particularly for pregnant women. And I think that the cost benefit ratio would be tremendous. And I think that we could probably, especially, one of the silver linings of the pandemic is that telehealth is a lot of barriers to telehealth are being knocked down or have been knocked down, like to make it sustainable that way. So that's one thing that we hope to do. We also hope to make somebody available right away just through secure messaging. So I'm a huge fan of peer navigators and community health workers. They're unbelievable resources that a lot of communities are getting more and more access to. I would love to be able to incorporate into the technology, and we're working on this, the ability to simply say, yes, I'd like a little bit of assistance, and a peer navigator or a community health worker can pop in and say, great, my name's Joan, how can I help? And let me see what resources we might have available for you. And I think we can do that instantly, and that would be a huge benefit. The other thing I think is to not underestimate the power of just attention, that even though we so much would like to have many more expert resources available to everybody who has these needs, if there's a healthcare team simply checking in and saying, how is that going? And, is there a 12-step group, or, what can we do in terms of helping you get signed up for Medicaid or anything else that might help you in any way? There's a lot of power in that. These brief interventions are not ineffective. They don't solve everything by a long shot, but they're also not powerless. And we do quite a bit simply by being there and being supportive.
There is a barrier, I'm just going to throw this out, that exists between sort of the behavioral health and that physical health. There are a number of us that are on the ground. When you talk about your peer recovery coaches, we've got our peer coaches, and we've got our recovery coaches, but they're not as readily accepted into that medical. We can't seem to, sort of deal with that divide, which would then help with some of the things that you're talking about. How do you suggest we go about that? I know that there are a number of organizations that are out here that have been knocking at the door saying, hey, we've got recovery coaches that we will pay for, that we will place in your hospital, let us in. And then, we aren't quite sure about that.
Yeah.
Help me.
I agree. That's a real obstacle, and one that I hope will ease over time. For now, I'm absolutely a fan of that happening electronically. So if we can actually connect them with somebody through that secure live chat right in that app, and by the way, that's a way of communication that people are more and more comfortable with. We text all the time. We text for support from friends or family. We text with, I get texts from my auto mechanic and my dentist. We just get texts all the time. That's one way that we can at least start that off, and then that gives that peer recovery coach a connection and an ability to then help in other ways, whether it's through phone or through true video chat. So although I don't have any good thoughts or solutions for how we might better incorporate them into healthcare settings, other than to share your enthusiasm for doing so, I do think that we could do so electronically. And I think that might go down actually pretty well if we're providing an application that does the screening for the healthcare system, that does the brief intervention for them, that gives them that report that they really want to get, and then also connects that patient to somebody who can help them if they need it. I think they would be delighted to see that that's just kind of being handled.
One of the things that one of our presenters talked about earlier is the resistance of many of our physicians to engage in SUD, substance use disorder.
Yeah.
And so if we're talking about pregnancy and pregnant women, we're talking about a very specific group of physicians, obgyns. How do we, what you want, and so what do you suggest to open the door to make sure that they, one, understand this is an issue, this is a concern, they are going to see it, and then how they can effectively address it. This technology is going to be amazing and certainly will assist. We also know that experts, if they're done, within that hospital setting, are reimbursable through insurance. But how do we then get our OB-GYNs, I'm just going to pick them, we're going to pick on them for right now. How do we get them to engage and to understand that this is an opportunity? We know they're busy, but this is also something that saves the lives of that parent and those children.
Yep, definitely. And I think they all, to the last one, they all very much want to help. They recognize that these are concerns. They just don't feel well equipped. They don't feel comfortable addressing it personally, and they feel like they don't have time. And just for example, electronic health records can often provide what are called clinical decision aids or best practice alerts, little pop-up that the doctor gets that says, hey, this patient has reported a high level of depression or substance use or something, you might want to do X, Y, or Z. They feel as if they get 10 of those for each patient sometimes, and like they have no choice but to kind of just clear them all. So I think the best way forward is a few things. I think to the last one, when I've talked to them, all they really want is something to refer them to. They absolutely are, because that's typical for them. If there's a particular risk, if diabetes is present, they want to refer out to a specialist, as they should, and they're really comfortable with that. And if there are behavioral needs like this, they want to be able to refer out to a specialist. So if we can provide them something to refer to, even if it's electronic, if there's a telehealth service available that covers a wide range that they can send the patient to, then they feel more confident, and then they feel more like they're able to do something. And they even feel more comfortable talking about it a little bit because they don't feel like it's all on them. So I think that's one piece. The other piece is that report that we generate provides some of this guidance. So rather than leaving them in the lurch of, here is a great big bundle of challenges that you were never trained in. Instead, the report says, this and this are present. Here are steps that you could take to try to make it really, really clear for them that they have a few options and that they can engage in those options. That's all I know to do. It's obviously a huge challenge. It's very, very difficult to get busy folks who don't feel comfortable with a particular issue to do more with it. But I think between getting some behavioral health specialists into those settings, between electronic availability of specialists, and between reports that can give very, very specific guidance, I think we can begin to make a dent.
All right, let's make that happen. And we have a resource here, also the Detroit Wayne Integrated Health Network and our behavior health and the boots on the ground. You hear, you've heard. And so the other thing is to make sure that we train our residents, the OBGYN residents, so that they are coming out with technology and with the resources and understanding of what's impacting our mothers to be. So thank you so much for your time and extremely well thought out presentation. Data, yay, I love it. And thank you for sharing your time with us this morning.
Thank you so much. I enjoyed it.
Great. Wow. You have heard a lot. We have been charged, we have been challenged, and we have been educated. So I want to thank Dr. Ondersma so much for a great presentation, and we're hearing in the chats and it's coming up. Everybody wants to do the same.